Okay, so this is the Thai patient, 73 years old. He's quite old, and he was referred from the another private hospital with the diagnosis of the AML. And by that time, the blast is positive about 57% in the blood. And from the study from, no, it cannot. Uh-huh. Okay, so from the study from the นี่ก็ไม่มีเคอร์เซอร์ไม่ใช่ผมจะเอา pointer มันก็ใช่สิอันนี้มันไม่มีเคอร์เซอร์ขึ้นนะอ๋อเหรอ Okay, okay. From the FIT study, it showed that PML LALA was negative, and PCR also show is negative, and the chromosome and next gen study is pending. So by that time, the white blood cell count is about 23,000 by that time at the previous hospital. So from our hospital, the white blood cell is about 6,000, and the platelet is about 73,000. And so this is the flow from the other hospital. It showed that the patient has acute myeloid leukemia. How you know that? I didn't mention anything. Okay, so this is from the FIT study. It's also shown negative for the PML LALA. So in our hospital, we did the bone marrow study, and it showed that the dry trapping. But anyway, from the touch preparation study, it showed that the patient has AML. So from the bone marrow biopsy, it also show AML and also the myelofibrosis that can explain why we cannot aspirate the bone marrow. Okay, by that time, the patient has 73 years old, and we discussed about the plan of the treatment. But usually, by this age, if the patient is not so strong, we may need only palliative treatment or conventional chemotherapy or targeted therapy. By that time, I discussed with the patient and family to make them, decide what to do. And then they agreed to use the decitabine for the front line first. And if it's not, work, then maybe add venetoclax combination. So by that time, we use the decitabine 20 milligram per meter square for 5 days for the conventional doses. And after 3 cycles of the treatment, we did the bone marrow test again. The bone marrow also show myelofibrosis. And by that time, it's no blast seen inside the bone marrow. And the test come back from the next gen study is positive for NPM1, TET2, and XPC, but it's negative for FLT and JAK2, CALR, and MPN also negative. But anyway, it looked like that the patient respond to the treatment. And with this age, we just try to, minimize the blood cell and palliative care as long as possible. So we reduce the medicine after we successfully bring the complete remission in this setting. And we reduce the doses of decitabine about 50% for the maintenance therapy after the patient got the complete remission. But after 2 cycles of the reduced medicine, reduce the decitabine, it show the blood cell in the blood again. It looks like that the patient has relapsed. So in that case, I add the selinexor for this patient, 20 milligram for 4 days. And after the 3 cycles, the patient developed the skin nodule, the whole body, and also the arm and leg. And it's look like it's more nodule every day. And also the small tumor mass on the eyes, it's look like benign tumor. And the eye doctor come to see him, and it look like benign, and suggest to do the biopsy. I said, oh no, we just a palliative treatment, it should be okay. But anyway, with this situation, I think that the patient, we did the biopsy again on the skin, and it showed that the patient have the skin involvement of the leukemia. And usually from my experience, if you have skin involvement of the leukemia, usually it's the end state of the disease. The patient will be die in the few weeks after this. So, but anyway, I did increase the doses of the decitabine to the conventional dose, 20 milligram per square meter for 5 days, together with the selinexor, because from the beginning we reduced the doses of the decitabine. But after we add on the medicine, the skin nodule look progress every day, and also the eye tumor bigger. So we don't know what to do right now, because the patient is old age, have diabetes, have chronic renal disease, and we try to avoid the chemotherapy, and we need less toxic medicine. So by that time, we consider the venetoclax to add on. But from my experience, I don't like venetoclax with the acute leukemia. Usually, it's not work and too toxic to the patient. So anyway, we have no choice. So that time, we looking for the alternative for the patient. We send the test with the Kun Tonhom, lovely name, Tonhom. Do you know what it means, Tonhom in Thai?
What is the connection to
Okay, so this panel, they offer about 10 tests when we send to the lab. So by that time, I just try to choose the targeted therapy that might be, more easy for the patients, and the patient can tolerate. In this stage, the patient cannot eat for about 2 months right now, and he got the parenteral nutrition for about 2 months in this day. Just takes the parenteral nutrition. So the design is about the new targeted therapy add-on and some kind of the chemotherapy if possible. But anyway, in this age, I try to avoid the chemotherapy. And the medicine that I decide is about bortezomib, decitabine, cytarabine, dasatinib, lenalidomide, cutilatinib, as you see. So this is the result of the test. You can see that for the single drug, selinexor is, the NCV is the concentration. If it's low, it's better. It will be sensitive to the cell, to the patients. And lenalidomide, and combination is selinexor plus the sorafenib, and selinexor venetoclax. You can see that decitabine and selinexor, as we use in this patient, the NCV is lowest in this case. How do you do? We already give this medicine to the patients. Because right now we use the decitabine plus venetoclax.
Sorry, can I show you something there?
Yeah.
Can you go back one slide?
Uh-huh.
No, go back one. Oh. Okay. So, may I? Do you mind if I just? Yeah. So my interpretation of this is actually uh, this drug, selinexor, is one of those drugs that works very strongly in a plate. Generally, I was mentioning there are some drugs that always kill cells inside a plate. Selinexor is one of those drugs. And so the combination, if you look at the NCV, is not very different from just the single drug level, which is kind of telling us that maybe this is largely just driven by the in vitro activity of selinexor. So comparing the two may be helpful.
That's it, this one. Yeah. So you can see that it's not touch the blue color. It's not touchable. 0.6 is also not touch the blue color. What about your experience in this case? It might be work or not work?
No. Again, to me, the red blue is a relative thing. I mean, we just made it, you know, randomly, right? This thing. But really, the importance is where is this patient in relation to other patients whose test has been tested for selinexor. So if you have 100 AML patients who have been tested for selinexor, where does this patient's NCV lie for selinexor? So it's comparing from patient to patient, not from drug to drug. That is for me, the more important value, which is not presented in this graph. So one must ask them for that information.
I'm not sure about the dose of selinexor for treatment AML patients.
Yes.
I'm not sure because I'm not sure
Yes, that is the point because the dose of the first selinexor that I use is only 1/3 of the recommendation because I use the low dose because the patient cannot eat any. Yeah, he cannot eat right now for 2 months, so I don't try to suffer for the patient more.
I do agree with
Yeah. Uh-huh.
because I got the patient that take the the bigger dose of the like selinexor and the patient got like fatigue and cannot eat anymore and like have the how to say adenophy not dysphagia something like that. So the dose is the overdose can cause of the like a fatigue or
Yeah, but for this result that support us that we should use the old medicine, it might work well. So by the time I increase the dosage to recommendation dose, the 3 times up of the selinexor, but the patients are still the same condition because he still cannot eat anyway. But he survived. So after we use the first cycle, so you can imagine the nodule, the skin nodule is decreased and gone within the only first cycle. So we continue the medicine. For now, is the last month, by the end of last month, the fourth cycle. But anyway, the skin nodule is reduced and gone, and the eye tumor, which is look like benign tumor, is also gone. It is a leukemic infiltration also, the leukemic nodule of the eye. But anyway, so by 16th of last month, this is the CBC. Even though the skin is look good, but the blood is a lot of cancer cell. The AML cells still a lot in the blood, is more than 50% every day. But the patient's stable. But he's stable, he survived. But right now, I cannot decide what to do. Add on the third medicine or change the medicine to give more remission for the patients. But it may not the right decision because the patient right now is, bedridden and cannot move a lot. if we add on the medicine, the patient will not survive and may have more complication. So right now, even though the leukemic cell inside the blood, but the patient is stable, the nodule is gone, and the patient still survive, cannot eat. Still cannot eat. But anyway, so this is the situation of the patients. So right now I am not decided what to do next. Just continue this old medicine and give him, as the life will be longer with this situation. He still cannot eat anyway.